Welcome. The microphone is yours.
Good morning. I see some faces I recognize. The mic that you have on my collar, that's for, I guess, the YouTube business and the other video. So I still need to hold this one probably. Okay. Yeah, so I see some familiar faces and thanks for coming out this morning. What I thought would make the most sense, because it probably impacts the most lives in my realm of medicine, is to talk about atrial fibrillation. Raise your hand if you've ever heard of atrial fibrillation. Yes, okay. That's almost 100%, just for the record. And I'm not going to get more personal, but I suspect some of you in this room might actually have atrial fibrillation. Last time I was here was 2018. This talk is a lot of that material. I didn't realize it had been that long, so it's 5 years down the road. A few things have changed. Honestly, though, a lot of the basic principles here haven't, and they never will. And I think it's just important to kind of review them, get a lay of the land for what we think about as practitioners when we're meeting someone with atrial fibrillation, some of the things that are going through our head, some of the treatment options that are out there. These slides, I understand you now have like a YouTube repository of talks or something. Pretty slick. So those can be on there, and I think they're just kind of a good foundational slide set for AFib. So it might be a little bit longer than people want, and I can go a little faster through some of it. But I think the central theme here is this is a really complex disease, and as the screen indicates, one size does not fit all. So we don't just have a recipe book for this is what we're going to do with every patient who comes in with AFib, because there's a lot of variety in terms of the patients and their other health conditions and their risk factors. There's a lot of variety in terms of how people subjectively experience AFib. Some people are tortured by it, and some people don't even know it's happening. There's a lot of variety in terms of how people tolerate the medications, etc. So what we do is almost always tailored to the specifics of that person's experience of AFib. So what is it? What you can see here on the screen, the bottom tracing is an EKG recording of normal rhythm. And you can see that it's nice and steady. And that purple arrow points to a little deflection on the screen that's called a P wave. That is your atrium sending a signal to tell your heart to beat. And then the big spike is the ventricle getting the signal. So up top, what you can see is a squiggly line that just looks like chaos. Welcome to atrial fibrillation. So we call that nice, and we call that not so nice up there. And that's atrial fibrillation. And one of the things you can appreciate immediately is your heartbeats are all over the place. There's a lot of variability to when your ventricle is beating in atrial fibrillation. And that has a lot to do with what people feel. What we call it, if you're looking for a formal definition, is SVT, which is supraventricular tachycardia, meaning something that starts in the top chambers of the heart, with uncoordinated atrial activity and reduced atrial mechanical function. So if you think about that uncoordinated feeling, it's akin to a car, a 4-cylinder running on 3 cylinders. And that's what a lot of people will describe. Back a couple thousand, 3,000 years ago, the description was, if the heart trembles, has little power, and sinks, the disease is advanced and death is near. Very dramatic. But that gives you a sense of what people have felt since time immemorial with atrial fibrillation. And luckily, I can say in 2023, just because you have AFib does not mean that death is near, but it was first described as a fibrillatory movement in the 1800s. And then Dr. Spector is a friend, a colleague, a brilliant electrophysiologist who famously described it as the Humpty Dumpty of arrhythmias. which I think is apropos. So some people say drums pounding in my chest, or thunder rumbling, or a fish flopping around. And for those of you who've ever experienced AFib, some of that might strike a chord in you. But again, there are others who will walk into the office being told they have AFib and say, I don't know what you people are all talking about or worried about. I feel fine. Causes of AFib, the actual list is never ending. I could fill screens of the hundreds of different things that might cause AFib. But it does get more common as you age. It does run in some families. Certainly, if you have heart disease or have had a heart attack, you're more likely to have AFib. If you have high blood pressure, you're more likely to have AFib. Obesity, thyroid disease, lung disease like COPD. If you have sleep apnea, that puts a lot of stress actually on your cardiovascular system and is one of the main causes of AFib. I probably order more sleep studies than just about anybody in this county because I meet the AFib patients. So this is kind of the common list of causes. Again, symptoms, palpitations. You might actually get a pain when you have AFib. You might feel dizzy or lightheaded or short of breath, even feel like your thinking's cloudy, like you're just not all there. Could get sweaty, get really tired and fatigued just walking across the room and say, well, that's new and different. What's going on? Well, might be AFib. There's also, beyond how people feel or how it makes them feel, there are a variety of other larger issues at play. And in a country the size of the United States with millions of people who have AFib, there are significant economic costs. There's drugs, there's procedures, there's follow-up visits. You can think about the strokes that happen related to AFib, clots going to the brain that can cause a stroke, bleeding events, either from a stroke or from a blood thinner that a person is taking, developing heart failure, which is weakening of the heart muscle. These are all things that can happen downstream after AFib develops, and it can get expensive to treat. Somewhere between 3 and 6 million people right now in the US have AFib, and the odds are, all the estimates for the last 10 to 15 years or so have been that there will be 12 million diagnoses of AFib in the US by 2030. Well, it's 2023 now, and so, you know, we're on track to potentially double the diagnosis of AFib in this country over the next 6 to 8 years. And, you know, that's partly because people are more tuned into it in terms of physicians looking for it. But that's partly also because there are a variety of wearable devices now that people are using and coming to us and telling us they have AFib. Apple Watches are the classic example. The largest study ever done on AFib monitoring was done by Apple Incorporated. There were over 500,000 people in a study to look at the validity of Apple Watch recordings. And the bottom line was, it's a pretty good data set. There are others that we think are even better. There's a device called Cardia Mobile, Cardia with a K, that can make recordings, but with the case that's on your smartphone, basically. And then when those recordings are made, they can be sent to an office as a PDF file. And so those recordings can actually get into a person's chart as part of their health record. So those are some of the reasons why the diagnoses are really ramping up. But for us, it's a little bit like an avalanche of AFib. I found this a couple days ago. This is just interesting. This is distribution of AFib diagnoses across the US. And you can see, I mean, sure, it's nice up here. We're relatively spared by comparison. And then look down in the Southeast US. You know, I'll leave you to ponder what the reasons for that might be, but places like Waffle House might have something to do with it. I don't know. there's a whole different approach to food in that corner of America. So that might be something to think about. So AFib, again, growing problem, and it's associated with significant morbidity and mortality, depending on how well it's being managed. There is a much higher risk of stroke if you have a diagnosis of AFib. It's about a 5-fold risk versus people who don't carry that diagnosis. And probably 20% or so of all strokes that happen in the US are related to AFib. They are usually basically more morbid events as well as strokes go. They tend to be larger strokes that are more disabling. So with that said, when we talk about a physician thinking about a patient with AFib, our number one priority is let's look at this person in terms of their stroke risk, and let's make sure we're doing everything we can to mitigate that. This is hard to see, I'm sure, from the back of the room, but this will be obviously in the slide deck that you can look at later. But what we use is this risk calculator that's called the CHADS VASC score. And CHADS VASC is an acronym which is listed down here on the left-hand side. It's congestive heart failure, hypertension, age, diabetes. Have you ever had a stroke previously? Do you have vascular disease? And what's your sex category? In other words, male or female, because there is a slightly higher risk across the board in women. So that actually gets you an extra point. So we just start adding up points when we meet someone and try to determine most accurately what is the CHADS VASC score. And if the score is 0, you don't really need anything. Your risk of having a stroke, even if you're having AFib episodes, is extremely low. If your score is 1, the risk of being on a blood thinner in terms of bleeding complications and etc. is roughly equivalent to the benefit that you're going to get from it in terms of reducing your stroke risk. So it's kind of a wash for people with a 1. But once you get to a score of 2 or higher, pretty clearly the data tells us those people should be on blood thinners. And so we make a point of very carefully assessing CHADS VASC scores. And again, you look at ACC guidelines, most recent update 2014, score greater than or equal to 2, oral anticoagulants are recommended, not may be considered, but are recommended. So that's why you would hear us push you in that direction if we're meeting you to talk about AFib management. So what are the drugs? Well, warfarin's been around since time immemorial, what some people affectionately call rat poison, which is what's known as a vitamin K antagonist, and it is a drug that has a therapeutic range, and you have to monitor it. And so there are blood draws every few weeks for people who are on chronic warfarin. It can be affected by what you're eating, so your levels can fluctuate significantly. And so it has to be monitored, and the doses have to be adjusted. There are a fair number of drugs that can interact with warfarin, and then you have to adjust the dose again related to that. So newer blood thinners were developed 10, 15 years ago, and large research studies were done on those drugs. And at the time, because they were new, they were called novel oral anticoagulants, or NOACs. They've since kind of changed the terminology, and you're more likely to hear it referred to as a DOAC because they're not so new anymore. What they do is they directly inhibit anticoagulation at a certain point in the pathway of events that happen to make a clot. So they're now called the direct oral anticoagulants. And the top 4 are there on the screen. The bottom one, Savesa, I don't know anybody who prescribes that. It has the least impressive data and never got approved for any drug to reverse its effects. The others all have reversal drugs. So mostly we have people on Pradaxa or Xarelto or Eliquis. If you look at head-to-head comparisons, there's a slight advantage to Eliquis. And so most of us in cardiology prescribe Eliquis. If we're having a hard time with people remembering to take their pills, Eliquis is twice a day. Xarelto is only once a day. And so sometimes for that reason, we'll have people on Xarelto instead, so that they're less likely to be missing doses. So those are the blood thinners, and I think it's important to impress upon you before we shift into anything else beyond this. This is standard of care. This is what we're going to recommend. This is the right thing to do for people with a CHADS VASC score of 2 or higher. That's what the guidelines clearly tell us, okay? This graph shows you how well we do at getting people on the blood thinners and getting them to stay on the blood thinners. So here are the different CHADS VASC scores across the bottom. Dark blue is people who are on warfarin, and then that dark brown band are the new drugs, and then up here are things like aspirin and Plavix, which are not part of the guidelines for people with elevated CHADS VASC scores. And then up here is nothing. And what you can see is, at best, we get to around 50% of people who should be on a blood thinner actually on a blood thinner. Keep in mind, this is just zooming in on that. If you're to the right of that red line, you're supposed to be on a blood thinner. And your risk of a clot and a stroke keeps increasing as you get over here. And what you see is, you actually see numbers of patients on the blood thinners tapering off over there. Those are the highest risk people. Problem is, their doctors are very worried about their very high risk of bleeding as well. Because people with scores of 6, 7, 8, 9, I mean, honestly, these are pretty sick people who have probably a variety of other health problems and are much more likely to have a complication with a blood thinner. And so sometimes their doctors just say, yikes, I'm not putting you on a blood thinner, I'm worried about it. And so then they're exposed to what might be an astronomically high risk of a clot causing a stroke. Even the new drugs that were originally known as the NOACs, you can see that about 30% of people who get on a NOAC were off it a couple years later for one reason or another. Somebody took them off of it, it got too expensive, they stopped filling their prescriptions, whatever it was. So these drugs are, recommended and do much better than not being on these drugs, but clearly not everyone can take them or can take them long term. And thankfully, this whole idea was developed, and this is basically a mechanical way to try to reduce someone's stroke risk so that you can get them off their blood thinner long term. And it's there are a couple of different devices, but basically the idea is there's a place in your heart that's called the left atrial appendage. That's like a little pouch that hangs off the front of your left atrium. And that is where the blood's moving slowest as it moves through the chambers of the heart. That's sort of like little eddy currents on the side of a stream. That's where the blood is most likely to pool and clot. So if you can remove or somehow eliminate the appendage from the bloodstream, then you can significantly reduce that person's risk of a stroke. And originally, the only way to do that was open heart surgery. You can have somebody like Jim Douglas in cardiac surgery cut it off and sew it shut, but that's a big open heart procedure. So these other devices have been developed to basically plug it like a cork, so that blood stops washing in and out of there. And then your body can grow some tissue over that cork, and then it becomes a smooth surface that looks like the rest of the lining of your left atrium. And then blood's not washing in and out of there, and then you don't have the clot risk, so then you don't have to be on a blood thinner. So the most studied device, and the one that is primarily in use in the US, is called the Watchman, which is now was a smaller startup company, was purchased by Boston Scientific. It's something we've been using since 2017. This is the current iteration of the Watchman called the Flex device. And what you can see is, I mean, it sort of looks like a marshmallow, right? It is a cage of this fancy metal alloy that is nickel and titanium. And then there's this mesh of fabric stretched over it. And basically this particular metal can be squished and twisted and compressed, and it will always pop back to its original shape. So you can put something like this inside a tube and deliver it inside a person's heart, and then it'll pop back to its original shape. And this is how we get these things into people. So it is indicated for people basically who should be on a blood thinner, who have a really good reason to not be on a blood thinner long-term. And one of the ways that we assess that is something called the has bled score. And this is another acronym of a variety of different risk factors for bleeding, basically. And again, it's hypertension and age and a history of stroke and other things like advanced kidney disease or significant liver dysfunction or heavier drinking is another thing that's on this list. And obviously a history of bleeding in the past. So as these things accumulate, you start to run up this other score called the has bled score. And so when we have somebody in front of us, if they've got a very convincing reason to be on a blood thinner, because their Chad's vasque is up in this range, and we're worried about their bleeding risk, then we start thinking about what else should we be doing? And that's where the Watchman comes into the conversation. And there's a variety, and again, this is more for your reference later, but what are things to think about in terms of not a good idea to keep this person on a blood thinner forever? Well, if they've had bleeding inside their head previously, well, that's a big one. If they've had bleeding from their gut, and when we first started the Watchman program, I will tell you the people who were sent to us first were the highest risk patients who'd maybe been in the hospital 3 times in the last year with bleeding from ulcers or something like that. And their doctors were saying, great, do that instead. It gets a little tricky because when you get a Watchman device, recall that there's this fabric business, right? Tissue has to grow over that fabric, and that takes a few months. And until that happens, that's a place where a clot can form. So people who get a Watchman have to be on a blood thinner at least temporarily. And the goal is that you get them down to just taking a baby aspirin by about 6 months after putting the Watchman device in. So there actually are people who are too high risk for bleeding to even get the Watchman procedure. One of the first people who got a Watchman with me, this occupation related to a high bleeding risk. He owns a roofing company, and he was on warfarin, and he was on roofs a lot. And he said, I'm not going to keep doing this. And so now he has a Watchman instead. So things like that come into play. This is just a little kind of graphic representation of here's a person's left atrium. Here's this little pouch hanging off. And you can see it has these ridges of muscle, just these little spots where clots are much more likely to form. And here's a Watchman device filling that space as we put it into the person's left atrial appendage. I don't know if this will work at all. These were, again, partly to have on that website. There is audio, but I don't know if it will play. It doesn't look like it's going to play. Hopefully, when this slide is on the website, you'll be able to get audio from it. But it's just kind of a little animation that shows how a Watchman is put in and that sort of thing. And there's a narrator talking you through it. So that's the whole piece of stroke risk, blood thinner, yes, no. Other approaches like sending the person for surgery to take the appendage off or thinking about a Watchman device, that sort of thing. Again, kind of priority one for us as the physicians. Now, we might be having those conversations with people when we first meet them for 15 or 20 minutes, and the whole time they're thinking, yeah, fine, whatever. What about how I feel? Because I feel lousy and I want you to do something about it. And that's often the patient's top priority is you got to do something about this. Every time this happens, I call 911 because I feel like I'm going to die. And there are definitely those patients out there with AFib. And so there are different approaches to trying to manage a person's AFib. And the way we think about AFib is this is a lifelong condition. We don't cure AFib in any real sense of the word. We have treatments for AFib, and we have ways to try to beat it back and push it out a few years and hopefully keep a person in rhythm for a while, not usually forever. And so when we start talking about our different treatment strategies, I think it's important for people to understand that what we're talking about is quality of life and trying to do whatever we can to maximize quality of life for as long as we can, but we are managing a chronic condition. Just like your primary care doctor might be managing your diabetes never goes away. It's well controlled or it's not well controlled. Think of AFib in a similar manner. So some people have AFib and don't have a lot of symptoms, and we will just make sure that their heart's not going too fast. And we've got different medications that we can use for that. And then we ask the question about the blood thinners and et cetera. And they are on a treatment strategy that we call rate control. We're just making sure their heart rate is kind of in a normal range. One of the things that can happen when people are in AFib is you get up and start to do some exercise. And, you know, normally if you were in normal rhythm, your heart rate might go to 120. And if you're in AFib, all of a sudden your heart rate's 170 or 180. And no wonder you feel lousy, right? And so what we're trying to do is take the top end off there with our medications so that your heart rate response is a little more normal during your AFib. But clearly, for some people, the symptoms just persist and they're miserable. And so they stop doing things they want to do. They stop going for hikes. They stop walking the mall. They stop whatever it was that they were doing, that there was their main form of exercise. They may cancel events and not spend time with their friends because they don't feel well. They're not able to keep up with their normal activities of daily living, or what we call ADL. It's too much effort for me to try to change the sheets on my bed. I get completely wiped out. I have to go sit down. Or sometimes we're following people who have AFib and we're watching their heart function, because we know that if they're having more frequent episodes where their heart races, they are more likely to develop abnormal function of their heart where the pumping efficiency is reduced, and that can put them into heart failure. And heart failure is essentially your heart is not able to keep up with your metabolic demands, and you feel that as fatigue, short-winded, etc. You may start accumulating fluid, retaining water, swelling. All of those things can be a form of heart failure that can be precipitated by AFib. And so if these things are happening, or if this person is just not doing well, then we have to start trying to figure out how to keep them in normal rhythm, if at all possible. And originally, that was drugs before some of the procedures that we do now were developed. And really, for all practical purposes, there's 6 drugs out there. Some of you may recognize one or more of these drugs because you may have taken them. Bottom line is they all have their issues. They all have side effects. They all have interactions with other drugs. Some of them have potential for long-term toxicity, like those bottom 2. Amiodarone has been around for over 50 years and is effective, but pretty toxic. Droneterone was developed to be amiodarone light, and quite frankly, I don't think it works very well at all, and still exposes you to some risks of toxicity. Dofetilide, which is brand name Ticacin, is a drug that we use a fair amount of in this community because it has a really favorable side effect profile. So people usually don't feel lousy on Ticacin. And then it just comes down to whether it's working for them or not. So these are, and kind of has to do with your other health conditions, your heart function, et cetera, your heart rate. All of these things are factors that will impact what drug we recommend. But these are some of the drugs that we use again, for rhythm control. We're trying to keep you in normal rhythm. So new drugs to prevent episodes is a big fat donut. The most recently approved drug on that list was Droneterone, and that was July 2009. A variety of drugs have been studied since then, and every single one of those trials has been stopped due to increased risk associated with the drug. So there you go. So in a void where there really aren't a lot of great options, procedures to treat AFib have evolved. And so what we do is what's called catheter ablations for AFib. Now, 30 years ago, the only way you could get your AFib treated with a procedure would be, again, during open heart surgery. And since the 90s, Dr. Douglas has been doing AFib surgery. It's called Maze surgery. And what they do is, and what they did originally, the first iterations of Maze surgery were literally to cut the left atrium and then sew it back together, which would create lines of scar, which blocked abnormal signals from triggering AFib. And I'm here to tell you that at the time, none of them really understood why that seemed to work, but it did. And so they did it, and they named it Maze because they were creating a maze the signals couldn't find their way out of. Now, Maze surgery has evolved over the years, and now what they do is a form of it that was developed by a surgeon named James Cox, and it's called the Cox 4 Maze. And they don't cut, they use cautery, or they freeze the tissue, and there are certain places where they're creating lines of scar. And now we understand what's triggering AFib in much greater detail. And so we go after certain spots inside people's hearts. And basically, your left atrium has veins that drain into the chamber coming from your lungs. Those are called the pulmonary veins. They're not supposed to have electrical activity. And in AFib patients, for whatever reason, something flips that switch on and they develop electrical activity, and they start rapid firing. And if those signals get out of the vein, you go into AFib. So our treatment is to try to throw up a roadblock so signals can't get out of the vein. And the main way that I do this now is there in the middle of the screen, Cryo Balloon ablation. It is freezing the tissue at the mouth of these veins. And there's a balloon that was developed to do that. And what that did for us was really changed the flow of the procedures, made them a more straightforward and predictable procedure, increased the success rate. In my experience, decreased the symptoms after the procedure, so people seemed to recover more quickly. So I switched to that balloon system in 2013, and last month was exactly 10 years of using the cryo balloon, and I've never wanted to move back to the original way we used to do it, which was cauterizing point to point. We have about an 80% success for people who have what we call paroxysmal AFib, which means it comes and goes on its own. And we have a lower success rate, 60 to 70% range, for people with persistent AFib, which means once an episode starts, it just keeps going until somebody somehow interrupts it, like by shocking the person's heart or by doing a procedure like this. And that's just, again, speaks to the fact that AFib is a chronic health condition. And the more AFib you've had, the more your heart gets used to AFib, and the harder it is to get it to remember how to be in normal rhythm and stay in normal rhythm. So we have more of an uphill battle, which is why, through the course of my career, what we have learned through a lot of research has been published on how to try to treat AFib, because it's such a growing problem in this country, is the earlier we get people into the procedure room to do this, if this is an important goal of theirs, the better the success rate will be. So as the tools have evolved and we've gotten better at doing this, it has expanded that pool of patients who we think are reasonable candidates for this. And yesterday I did an AFib ablation on a 45-year-old guy who has started to develop AFib over the last couple of years and does not want to spend the next 40 plus years of his life on one of those drugs. And it was very interesting because in that, you don't always see this, but he came in normal rhythm. I started the procedure and I was mapping his left atrium and he went into AFib. And then as I treated the veins, I could see the signal in each vein disappear. And then when I got to the final vein, I started that treatment, and about 20 seconds into that freeze, his AFib stopped, and that was it. It never started up again. So it made me feel like we were definitely treating the right place in his heart. So that's, that's kind of basically gratifying when you're the one who does that and you see that. You don't always see that, but that was one of those moments, and that was yesterday. This is another little video, which again has some audio, but if I play this, and I don't know why that one doesn't want to play, but it would show you the little catheter being introduced. Basically, it comes up from the person's groin through a vein up to the heart. We cross from the right atrium into the left atrium, and then we treat the veins in the left atrium with our little balloon system. Now, for some people, the problem is this is AFib with a heart rate of about 30. And for some people, the problem is they have a really low heart rate with their AFib. And for those people, unless there's a drug that's doing this that we can eliminate, really the only effective treatment is a pacemaker. Now, pacemakers have gone through a lot of iterations and a lot of evolution as well. They were first developed in the 1950s, and I've got a photo somewhere on my computer of a person with one of the first implanted pacemakers with wires surgically attached to the outside of their heart, hooked up to a machine that was about the size of like a dishwasher on wheels that they were pushing around the hospital with them. Okay, so it's a little better than that. And the goal with the device companies for 40 plus years has been to try to make them smaller and smarter and last longer. Over the last decade, also making them compatible with MRIs has been an important theme that they've been pursuing. And so this graphic kind of shows, once we got past the dishwasher, we were at something that looked like this, and then gradually getting smaller and smaller. These are Medtronic devices. That's one of the main device companies. But the weakest link with these systems has always been the wires. Traditional pacemakers go in your shoulder, wires go into the veins, then down to the heart, attached to the heart muscle. And if your heart's beating 70 beats a minute, your heart's beating over 100,000 times a day. And they have to make these wires flexible and strong so that they can move with your heart 100,000 times a day for years and years and years and not fall apart. And I actually, yes, I deal with people who have wires that have problems. I had to add a wire to a 93-year-old's pacemaker yesterday because one of the wires broke and she uses it a lot. So these are the issues that can come up. But I actually, to the credit of all of these device companies, I actually think they've done a remarkable job. And the fact that we can expect wires to reliably work really well for 15 or more years in most people is pretty remarkable. But that's the weakest link. Clearly, that's the weakest link. So they've got to be flexible and strong. They're also a place where if you get an infection in your bloodstream, it's a great place for bacteria to grab onto a wire and start to grow, and you can wind up with an infection that essentially is affecting your heart thanks to having a pacemaker wire in your heart. So in response to those concerns, this little thing was developed, and that really doesn't show you the scale. I'll show you the scale in a minute, but this little guy is called a micro pacemaker, and that's the whole thing. There's no wire attached to that. That is just attached to the inside of a person's heart, and has a battery life of 8 to 10 years. It only can attach to a person's ventricle. It doesn't work in the atrium. They're working on that. And we might at some point have a system with two of these. One goes in the atrium, one goes in the ventricle, and they talk to each other. And they could work for people who are still in normal rhythm but have conduction problems. We're hoping that that'll be on the horizon in the next few years. But if you have AFib, all you need is something in the ventricle, because the atrium's just out of rhythm all the time. And so this can become a really attractive option. A lot less to go wrong mechanically, and a lot less surface area to potentially get infected, for instance. This little video will sort of show how these things are put in, and this is worth a quick look. Let me just scroll ahead a bit. So we put in a tube in the groin in a vein, and we run that tube up to the person's heart. Then once we've got the tube in there, we advance the pacemaker. We attach it to the muscle of the right ventricle with these little prongs that grab the muscle. And then we test it and check it and make sure it's a good spot, it's getting good numbers, and it's pacing the heart, and there's a tether attached to it. And then when we're happy, we cut the tether, remove the tube, stitch the person's groin, and they now have a pacemaker. And they have nothing up in their shoulder. And here's a comparative size. That's a multivitamin. That's how big they are. So, we're really grateful that that technology was developed. And that's really, that's revolutionary. That's really changing the technology. That's a fundamental change compared to previous pacemaker technology. And that's not for everybody, but that's definitely for some of our patients. And in particular, we'll tend to put those in people who are in permanent AFib and having low heart rates or lightheadedness, dizziness, fainting, that sort of thing. So just to summarize, clearly a growing epidemic in this country, very costly, a significant increased risk of stroke, and that's why we focus so heavily on that when we talk to people about AFib. Some people can just be managed with what we call rate control. Others really need rhythm control because the symptoms from their AFib are really disabling. But if we're pursuing rhythm control, the real message is sooner is better than later. And there are drugs and there are ablations. Certainly ablations are not for everyone, but they can definitely help manage disease symptoms. And what we've learned is when we study ablations and drugs head to head, ablations do better long term than the drugs do. So that's why we've kind of moved in that direction. And again, for some people, pacemakers are the right move. So this is what treating AFib often feels like for us. Maybe didn't bring quite enough equipment to the fire, but we're trying to grow to meet the demand, and frankly, one of the bottlenecks is the ability to get people in for procedures, and it's not just in Bellingham; it's all over the place. There's a limited amount of resources available. Physical space, procedure rooms. This month, actually, we are opening a new procedure room at the hospital that's called a hybrid operating room. And that's basically a full-blown OR that also has all of the advanced imaging equipment that I need to do what I do with ablation procedures. And so that's a nice combination, and it'll be a pop-off valve that we'll be able to use sometimes to help just get people in. And ultimately, the goal is 2 rooms that we can run full-time, and then we will have the capacity to have a third electrical doctor in town. We have two, but we actually need more infrastructure to really support three, but that's the goal. So that's just where our field is heading. It's expanding, not contracting. So we're busy. All right, I'll leave it at that, and I'm at your disposal for questions. Yeah.
If I may interrupt, I got a microphone here, so if you have a question, put your hand up so we can all hear you.
Great.
Here, Larry.
Has there been any study of correlation between COVID and AFib? Is it increasing in any shape from the pandemic that you're aware of?
So there have been a variety of types of arrhythmia that it appears increased, at least temporarily, associated both with COVID infection and occasionally with COVID vaccination. We have clearly seen people develop arrhythmias that were vaccine related, and during an infection. It's not just COVID. Any significant stress on your system, regular garden variety pneumonia, having the flu, being hospitalized with a kidney infection, whatever, that type of systemic stress can trigger arrhythmia episodes. So we often meet people to do a consult for AFib because they were in the hospital with something else. They broke their hip and they're having to have hip surgery and they're in a lot of pain, and whoo, all of a sudden they're in AFib.
Yeah.
Right. So anything that kind of upsets the apple cart can trigger AFib.
Okay, and you mentioned Plavix
Yeah.
as one of the blood thinner things. It has been described to me as a temporary kind of a drug, but I've been taking it for a long, long time. I'm wondering whether I'm way off base.
Well, I wonder what the original reason was it was prescribed. It is used in the most common setting is Plavix is used in people who've had a stent placed in their heart to prevent the stents from clogging up, to prevent another heart attack. It is sometimes used in people who had a stroke where they couldn't figure out why the person had a stroke, but they're worried about blood vessel disease. And Plavix makes little components of your bloodstream called platelets slippery, so they don't stick to each other, and you're less likely to form a clot that is a clump of platelets if you're on Plavix. That's not the kind of clot that tends to form in AFib. So it's not really part of the AFib guidelines.
I see.
It's used, but there's not great data for Plavix in AFib.
Long-term, it could be long-term then in my case, I
Yeah.
imagine. Okay, thank you.
Yeah.
Yes, sir. I've been a registered nurse for 55 years. So in looking at that picture, I want to so thank you for the work you do. My daughter is an EMT paramedic captain out in the county. I'm in this state because 20 years ago, and I did move from where I was eating grits and gravy in Florida. That said, in 50 years in Connecticut, and at Waffle Houses. The bottom line is I was always very concerned because with her 3 pregnancies, she had a significant, tachycardia and was from Hashimoto's, and she doesn't mind me saying that, thyroiditis, et cetera, and toxemia. That said, I'm not pleased with what she chooses to do in response. She's had a thyroidectomy. Have you treated or have you seen? Because I mean, I was blessed to work long-term care here to have 1 day off, but on bed rest, I mean, her pulse was like 120, whatever. And now she's had a thyroidectomy. Do you see with either other pregnant women or other people that you treat I mean, I did have an event from, I would say the inoculation, I never call that a vaccine, and I'm on metoprolol now. That said, is there anything, now she has her adrenals, do you treat, is that considered, I said thyroid here, is that considered something that she needs to be very watchful? The only thing she's on, honestly, is, and what do you think about an 81 milligram aspirin?
So thyroid disease is a very common trigger for AFib in particular, and a variety and other arrhythmias as well. And people with Hashimoto's is very common for them to develop AFib. And it can be really difficult to control the rate. So until they get the thyroidectomy or they get whatever more definitive treatment for the thyroid, it can be really hard to manage their AFib. Usually things will settle down though, and then they wind up on a thyroid supplement because they've had their thyroid removed. And now we've got normal thyroid hormone levels and everything's okay. That may be one of those scenarios where that's a reversible cause for AFib, and they're not going to keep having AFib for the rest of their life because there was that event. But, you know, remains to be seen what happens long term. Now, for a baby aspirin, the answer is if there's a history of AFib and a CHADS VASC score of 0 or 1, we will tell people it's not going to hurt you. There's not a lot of great data for it helping you. That's basically what the guidelines say too. There's been a couple back here for a while. Okay.
Well, I got this book, my primary care recommended the AFib cure. And it's, I don't see anything inconsistent with what you said and what's in here. I guess the comments I've seen online criticizing the book are all about the strictness of the diet that they recommend in there. Do you, what are your thoughts on diet as a?
I'm going to level with you. We don't have time to enter into conversations with people about how to adjust or manage their diet. And that is a fact of life in modern medicine. I think there's a lot of merit to it. I've got one patient who swears by his intermittent fasting / ketosis diet as the reason why he doesn't have AFib anymore, to the point at which he encouraged me to submit an abstract to try to get a poster at a national meeting, and they rejected it because it was kind of anecdotal. But the point is, I think there's merit to it. There are so many iterations of different diet plans that, you know, people claim have all of these downstream effects that are anti-inflammatory and et cetera, that I think the jury's out as to which diet plan would be the best diet plan. And really, one of the main issues that we run into is we've got somebody in front of us who is pretty severely obese and needs simply to lose weight by whatever means possible as a treatment strategy for their arrhythmias, and to even put them in the ballpark where we could talk about an ablation, because if somebody's BMI is too high, it's too risky to try to do procedures like that on them. And so we've started to just focus on, we need to figure out how to help you lose weight. And we actually have a new resource in this community to whom we're sending these patients. It's called, there are 3 things that they are treating, and it's something like diabetes, weight loss, arthritis, or something like that. And it's Dr. Gelou, Gelou, and he and his wife have opened this clinic. And so I am referring patients to them. Now, they do have a focus on diabetes management and obesity management. So I don't know from experience talking with them how into the weeds they go with specific diets, but it's obviously important for arrhythmia management. There's no time for it. And I mean, honestly, it's not reimbursed. It's just like one of these voids where the whole medical system, if you want me on my soapbox, this whole medical system is geared toward putting out fires, right? This whole system is geared toward putting out fires. It's very expensive to put out fires. It's expensive and time consuming, and the building's on fire. Like, let's do some fire suppression. Let's put in some smoke alarms. Let's do some stuff that prevents this, but that is not what is incentivized in this country.
Dr. MacGregor, just two, I think, pretty short questions. Number one, is the cardio mobile device compatible with pacemaker?
Yeah,
It
that's fine.
is.
Yeah.
Because they're, last I looked, they said it wasn't, that's the cardio website said not compatible. So that has changed then.
Yeah, I mean, you mean in terms of an interference
Yes.
between the two? Well,
Yes.
so the answer to that is you shouldn't put any mobile device in a shirt pocket right in front of a pacemaker.
Right.
But once you get, the potential for electromagnetic interference decreases by a factor of 4 related to the radius away from the device. So it drops off really quickly. You just put something out at
Okay.
arm's length.
So they are probably being very, very careful with
Yeah.
it now. Second question, can I trade my current pacemaker for the new device? I got the big one up here.
Can you trade it? Well,
I don't want to trade it in, but they do.
so I've had some people come in with the standard pacemaker with wires, who have a problem, a mechanical problem, say with a wire, who are very thin and frail at this point, maybe in their 90s. And I've put the Micra in and just left their shoulder alone completely. Just leave it there, abandon it, and put in a Micra. I've done that.
You don't clip the wires of the leads of the,
No,
Hold
I mean,
on.
just, if you don't have to open the pocket and manipulate any of that, that's best, because any procedure up there is a risk of infection.
thank you.
So,
I'm gonna work this side of the room, then go over here so I don't go into AFib myself.
Hi, doctor. I just wanted to ask you, is the cardiology department of Peace Health expanding? It seems like there are so many doctors there already, and yet we know so many people, including, my husband, who have heart issues that it seems like when we contact his doctor, for example, there's a long wait, as in almost every event in medicine nowadays, I guess. But is it expanding at Peace Health?
so it has expanded over the last 2 years. It has increased by a total of 4 providers. There's one more coming this summer. The next one after that will be number 3 electrophysiologist, once we've got some pieces in place. Right now, the problem is they can't add any more providers to our office building. It's full. And a remodel has to happen so that providers will have a place to sit down. But there are, I think it is, it's either 26 or 27 providers in cardiology. What I mean is MD, nurse practitioner, or PA. 27 right now. And when I moved here in 2006, I think it was 14, 13. So we've essentially doubled our capacity, and it's not enough.
Mhm.
And, since I moved here, our catchment area from which we draw patients has grown by about 25%. So there's just that absolute number, right? But also our population has aged, and now we've got a bunch of baby boomers with cardiovascular problems. And this is a national problem.
Mm,
It's a tidal wave of humanity. And we don't have, I mean, we don't have the medical system doesn't have the infrastructure in place to deal with it. We would have needed to expand med schools 10 years ago to
Mm.
deal with this,
mm.
and we didn't. So,
Thank you.
No different at the grocery store or the gas pumps. Somebody back here?
Thank you, doctor, for sharing this information. I have a question concerning something you mentioned earlier in your presentation, that most of the things you talked about were treatment and not cures. What longevity might one expect as far as success of the ablation treatment?
the success rates that are quoted are based on research studies, and that is freedom from AFib at 1 year. 1 year. Now, that being said, does it drop off after that? Yeah, to some extent. And that has a lot to do with what are the underlying risk factors and is the person managing them, honestly. You know, that's an important message to try to keep driving home is this isn't Jiffy Lube. You don't just come in for an oil change and everything's all good. This has to be a partnership and people have to commit. I mean, we're committing significant time and resources to doing things like catheter ablations, but we need some reciprocity and we need people to stick with the plan and really try in good faith to keep themselves healthy after that, because it makes a difference to the long-term outcome of the procedure. It does.
My question is, after an ablation, I was thinking that was kind of a cure-all. I'm now going in for an MRI and another ablation is set up for me. Why is there two in line for me within 2 years?
2 ablations?
Yeah.
Well, it depends on what, is it AFib?
AFib.
So if there was some response to the first procedure and then things got worse again, then that's a clue, at least to me, that we were treating the right area and something wound up finding a way to reconnect and need some additional work.
Okay.
If the first procedure made no difference to that person at all, then we weren't treating the right area in their heart and they have AFib coming from some unusual spot. And I'm definitely less optimistic that a second procedure is going to make any difference for that person, because if their AFib's coming from some unusual spot, it's like looking for a needle in a haystack.
So is that why there would be an MRI ahead of the procedure?
The MRI data is actually something developed through University of Utah, where Dr. Barakat and I both trained for EP. And the idea was to look at fibrosis in a person's left atrium. Fibrosis is another word for scar. To understand how diseased that chamber of the heart is. The more fibrosis, the less likely it is that an ablation is going to work. And so the data, they've parsed the data out and separated people into 4 different groups based on their fibrosis and labeled them as stage 1, 2, 3, 4. Stage 1 and 2 patients do really well with ablation. Stage 3, you may want to think about doing more extensive ablation than you would have normally because they're stage 3. And stage 4 patients, which means their fibrosis is above 30% of the atrium by volume, it's probably a waste of time to take them to the EP lab. So that's why we're doing MRIs now, so that we can understand what we're getting into, maybe modify the procedure if we need to, and level with people and say, this is realistically what you're looking at.
Thank you.
What was the evolutionary purpose for the appendix on the heart? Do you have any idea?
Yeah, it's an interesting question. We do know that it's capable of triggering production of a protein called atrial natriuretic peptide in response to increased pressure inside the left atrium and a stretch stimulus. Your body will produce ANP, which is basically your own homegrown diuretic. So it'll make you pee. And it's very common actually to hear people say, every time I go into AFib, I'm up all night peeing. It's probably atrial natriuretic peptide being produced because the pressure in the left atrium goes up when it loses its mechanical function. That's about the only thing though, that it seems to be the point, and you certainly don't need it to live, much like your appendix.
Dr. MacGregor, first I have just a comment about the doctors Gelou, Gelou. I'm not their agent, by the way, but I volunteer with Sanjay Gelou on a diabetes and kidney health awareness initiative. And they do great work. As you said, you referred to them. I just wanted to say that, you know, I'm sure she'd be really happy that you're referring. But anyway, so that said, you know, as far as not everyone being in AFib being a candidate for ablation, so is there a way to describe who is a candidate? And I know this is anecdotal, but my sister has fairly recently developed AFib, and she doesn't live in this area. She lives in Seattle. And the medical practitioners keep pushing her to have the ablation, but something comes up and they're the ones who cancel it because something else came up. And so if it's so urgent, I don't know. I'm so confused because my sister Pat, she's been whipped back and forth like, oh, have the ablation. Oh, we can't do it now because something else is more urgent.
So the short answer is most people can be candidates for an ablation in the right circumstances, with a few exceptions. Age is relative, but that said, I don't think I'd probably have anyone in the room for an AFib ablation over about age 85. That's a higher number than it was when I came out of training. But so there's that. There's BMI or body mass index. Above about 40, there's a significantly increased risk just during the procedure if something starts to bleed. Very, very difficult to get it to stop bleeding. Also, above a BMI, you know, up in that range, people are much more likely to have a lot of fat around their heart. Honestly, it's called epicardial fat. And it seems to be able to signal tissue locally, and maybe one of the triggers for AFib, and maybe a reason why ablations don't work as well in those people. So that's a potential issue. Bad kidney disease is a potential issue. Very underweight patients have a higher risk from ablations as well. So those are some of the things that we think about as red flags that maybe this is really not a good idea. But you know, to be a candidate, you gotta have AFib, either paroxysmal or persistent, but not for the last 10 years. You know, day in and day out, because I think it's probably game over at that point. It's got to be causing you symptoms or affecting your heart function. You can try a rhythm drug first. You don't necessarily have to. Certainly, if you've tried and failed a rhythm drug, that's a great time to talk about an ablation. For the 45-year-old yesterday, he didn't want to talk about a rhythm drug. So it was first line therapy for him. You know, so.
Okay, this is from an online participant, Rebecca. She says, why do I have AFib after the pacemaker was inserted? She had a pacemaker inserted 3 weeks ago.
I love that question. Thanks, Rebecca. AFib is very rapid. Remember that one of those first slides, rapid uncoordinated activity of the atrium. When you're in AFib, your atrium, if you try to count the electrical impulses per minute, it's going to be probably north of 400 impulses per minute. And they are bombarding an electrical junction in the center of your heart called the AV node. And the AV node is doing everything it can to just act like a governor and slow that down so that your ventricle doesn't go 400 times a minute, because you would drop dead. And so the AV node is functioning like a governor during AFib. So the message there is AFib is all very rapid activation. That's not what pacemakers are for. Pacemakers are for people who have slow heart rates or signals are not getting through from top to bottom, and they need the pacemaker to prevent them from running too slow or passing out, that sort of thing. Now, occasionally pacemakers will be put in someone in whom everything we've done to try to treat their AFib has failed. They're in AFib all the time. Their heart's running fast, basically all the time. And we put in a pacemaker, and then usually a few weeks later, we will cauterize that junction, the AV node, rendering them dependent on their pacemaker from then on, but they stop having fast heart rates, and now all of their heartbeats come from the pacemaker. So that's another scenario. And for instance, if somebody's got a normal heart, we could put that micra in, and we can cauterize the AV node, and now all the heartbeats come from the micra. But bottom line is pacemakers cannot treat AFib. Pacemakers treat slow heart rates.
On another question from her, she did get the pacemaker put in 3 weeks ago because of bradycardia. Does that affect the 13-year battery life? In other words, it has to work, seems like more.
Battery life on a pacemaker is impacted by how frequently people pace. But if they have a good normal capture threshold, which is how many volts are required to stimulate the muscle, the battery life projections are based on pacing a high percentage of the time. So that should be an accurate estimate. And those estimates update on a rolling basis. So every time they have a device check, you get an updated battery estimate too.
Grateful November 2nd patient of yours, so thank you for my ablation. My question is, I'm faithful on my Apple Watch and my workouts. My question is, sometimes it says it can't register or not register AFib because my beats per minute are low. Is that normal?
That's probably normal for you.
Okay.
So I honestly don't know the inner workings of Apple. Is that Apple?
Mhm.
Of Apple's algorithm. But it may be that if someone's rate is running below 60, its algorithm isn't as reliable.
Okay.
And you can have a steady rate of normal rhythm and have an extra beat or a premature beat that interrupts the pattern. That's not a fib. It's just a premature beat. And depending on what tool you're using, it can get confused and say things like possible AFib and that sort of thing when it's not.
Okay.
So they aren't perfect tools for
Okay.
sure.
Thank you.
But yeah, I would bet just the lower heart rate just messes up its algorithm. Yes. Okay.
Hi, I'd like to ask you, after I went on thyroid pills, I'm having a problem. Did you say that could trigger AFib again a little bit worse?
If you're on a thyroid supplement and it's more than your body needs, then yes, it can.
Because I feel like I'm racing all the time.
Yeah, and it can certainly even trigger AFib. So you want to be sure that you're not being over supplemented.
Okay.
Okay,
And now this Watchman.
Yeah.
Device, can someone with a pacemaker have that done if?
yes, absolutely. Yeah, and someone who's had an AFib ablation can have it done.
I have had that. done
And
twice, I
someone
think,
who
yeah.
has a Watchman can have an AFib ablation later after that, and et cetera. So these things can be, they're just done at different times, but they can all be done on the same person.
So the Watchman, that's more or less to get off your blood thinners, then I wouldn't have to go every so often for pro time.
True.
Okay.
Now, but I will say that just not wanting to get a pro time, depending on who the insurance company is, that may or may not be adequate justification to do a procedure
Okay.
like that.
Yeah, okay. All right, thank
So-
you.
Back of the bus.
Dr. MacGregor, I'm an old patient of yours at 94 years. I've been,
Have I been doing this for that long?
actually, I have been cardioverted 8 times in the last 15 years, the most recent being last month. How do I get to see you? You take referrals only?
Yeah, if you see another cardiologist,
Right.
you just tell them you want to see me.
I only see him twice a year.
Yeah, and then they just do an internal referral to have their patient seen by the electrophysiology team, and you can you can say, I want to see MacGregor.
Thank you.
Yeah. Yes. Yes.
I am a nurse. I am 77. My advanced directives are done. I'm definitely a no code. I want to go home whenever, and I have other disease. Is an ablation or any of those things? Because I say, like, I tell people, no, I mean it. I am a DNR everywhere I go. That said, is an ablation ever, if somebody called an emergency room and I ended up there, is that ever done like in an emergent thing? Because I don't think if I'm a DNR and I don't want anything done, the good Lord's taking me home, they wouldn't do something and seeing that as emergency, right?
Correct. In general, the stuff that I do is never an emergency procedure. These are almost always elective procedures. When you're talking about AFib, it's all exclusively elective procedures. Now, we do occasionally do ablations for other rhythm problems more urgently on inpatients. And as an example, somebody who comes in with a tachycardia that's called AV node reentry tachycardia, it's a form of SVT. They might have a heart rate of 200 beats a minute, and it becomes incessant. It won't stop. They keep converting the person in the emergency room, and then it comes right back 10 seconds later. That person's going to wind up getting an ablation done as an inpatient, like probably tomorrow, because nothing else is working. So that's the one scenario where we do ablations more urgently. And then to the DNR piece, just so everyone knows, when you undergo an elective procedure, whatever your code status is, that is suspended during the procedure. If you have a complication during one of my procedures, you're going to be treated to save your life. We're not going to go, oh, they have DNR. All right. Looks like we're done here. So code status is suspended during procedures.
Okay, Mary, you're gonna make me give one to AFib.
Do you recommend maybe anybody over the age of 70 to have just one baseline cardiology appointment? Just to see how their heart's working?
That's an interesting question. I think it really depends on how you feel your primary care physician's doing with annual assessments. Are they asking you the right questions? Are they getting an EKG? Have they asked you about changes in exercise capacity? Are they checking your lipids? Are they addressing your blood pressure? If you feel like your concerns are really not being addressed to your satisfaction, yeah, you should go see a cardiologist. I get that. Yeah. And yeah, I think it's reasonable to do that. I don't honestly, off the top of my head, know if there's some national guideline that says that should be standard of care. But again, I think on a case-by-case basis, if you're concerned that maybe there's something not being addressed, that's a great idea. All right. Yes. And for people who have intermittent symptoms, the first thing we do is a heart monitor that's a patch you wear for 2 weeks. And if you don't catch anything on that, but the person comes back 3 months later and says it happened again, then we have a monitor we can insert under the skin that's called a loop recorder, and they last about 3 years. And they're monitoring your rhythm 24/7. So that's another longer term monitoring option if it isn't being caught any other way.
Okay. I just got one statement before if I give it to Diana, we'll be here all day, so. There's about 6 of us in the room that have been part of this since the beginning 10 years ago. And I've noticed in our monthly meetings, there's a correlation between how good the speaker is and the number of questions. We had a hell of a lot of questions today, so thank you very much, Dr.
Must mean I'm not addressing the right stuff. I don't know.